I'm so glad you're here. This is a replay of a live training I did inside the OTs for Pelvic Health Facebook group with Lindsey Vestal, and I wanted to make sure that everyone gets access to it. Pelvic health is such an incredibly fulfilling specialty, and it's growing so much. I've been training OTs since 2018, and my goal is to have over 10,000 OTs trained by the year 2030. I'm so glad you're here learning about this specialty. I hope that you can join us in the OTs for Pelvic Health Facebook group with me, Lindsey Vestal. I will link to the group below in the show notes and description. Thank you so much. Woohoo! It is time for OT Empower Hour. Today's topic has one that I have been so excited about since I think early this year, and it's finally happening. We are talking today about incorporating pelvic health at the inpatient setting. This is so awesome. This is something that we don't talk about enough. And I have to say, a lot of questions and a lot of comments come in through the Facebook group. And I am always turning to Rebecca Hearst to answer my questions. Rebecca, welcome to OT Empower Hour.
Thank you. Good to be here.
Woohoo! I love this. I love this. I'm sure we're going to have so many questions coming in. I've got a ton myself. Before we launch into today's topic, there are two things that we have to do. Number one is our icebreaker question. And number two, I just have to make a brief announcement that in about 2 weeks, the prices are going up for our OTs and Pelvic Health Summit. It is happening on August 19th and 20th. The agenda was just announced earlier this week. It is incredible. I am so excited with the breadth and width of expertise. We have OTPs, we have PTs there, and the energy was so vivid last year virtually. I just can't even imagine. So please pick up your tickets before June 15th when prices go up. We have an amazing charity function happening on Saturday night for the Fistula Foundation. I'm jazzed up about that. The reception Friday night, our swag bag, it is so worth swooning over. So enough about that. I'm going to put the link in the comments. Please join us. We're so excited to have you. And Rebecca, I got to start off with the icebreaker question for you because it lets you and I know who's joining us, because I encourage everyone to join in the conversation and let us know the answer to your question. And here's mine. Okay. Do you prefer, notice I'm not saying do you drink, do you prefer Coke products or Pepsi products?
Coke, no question. Coke.
What is the answer?
Coke.
Coke, yes.
Yes.
Okay, I'm so glad you said that. I have to say, it's Coke for me too. So we recently moved to Flagstaff, Arizona, and it's so interesting how regions take on a brand. Like, have you seen that before?
Oh yeah.
Everywhere here it's Pepsi. And I don't drink soda very much at all, if ever, but I definitely would go for a Coke, and all I see is Pepsi. What do you have in your area?
Well, we have a lot of Coke, and I will pick certain drive-thrus knowing which one has Coke. If it's just Pepsi, I'm like, okay, anyway, I'll take a water.
It is so funny. All right, everyone joining us live or on replay, let us know your preference, Coke or Pepsi, if you were to drink, if you were partake, or if you currently do, no judgment. But I'd love to know if you're a Pepsi or a Coke drinker. All right. Rebecca, I'm gonna share your bio because it gives so much context to our conversation today. So you are a former OT Pioneer alumni, which I'm so excited about and proud of. And your expertise has grown so much, and it has been beautiful to witness. So you really enjoy the process of seeking clues and problem solving what we could call the puzzle of incontinence at the rehab hospital.
Yes.
You absolutely believe that OTs are experts at activity analysis and toileting, and continence is no different. And what you saw was that if OTs and nurses were curious about why someone was having incontinence, they often didn't know where to go, right? Like, there's not a playbook for this. And so, we know that regaining continence is incredibly important with our clients. And so with education and modeling of how to be a good detective, staff all staff are able to really incorporate these strategies and interventions to help our clients with their continence issues. And you are on the forefront of that, my friend.
Thank you. Yes.
Awesome. So I want to pick your brain now. And again, anyone joining us, feel free to join in with any questions in the comments. And those watching on replay, Rebecca is a definite, pretty popular member in our group. So I'm sure she'll see your questions come in. So Rebecca, my first question for you is a really basic one. Why should pelvic health be addressed in acute and inpatient hospital settings?
I was thinking about this earlier, how what I noticed was patients that we see in an inpatient setting or acute, they're people before they're patients, and they're still people as patients. So just because they're in the hospital and on your caseload and working on, post-CABG recovery or hip surgery or something like that, some of those things that are still part of that person need to be addressed, and they weren't being addressed in some cases. What I saw was some people started to have incontinence after surgery. After different kinds of surgeries, I noticed the same thing, and they came to rehab as incontinent, and on the report at admission, they were labeled as incontinent. And so it was very easy for staff working with them to assume that they had had this problem for a long time, and that it was just on, not an acute issue when it really was. So, so I started seeing some of the clues that I was like, wait a second, all your clothes are normal in your closet. Your wife isn't bringing a pack of diapers. Why are, so to think in a holistic way, just because someone's there for a short 2-week stay in rehab, you need to still look at the whole person and not just their hip or their sternal precautions.
I love that. I love that you just illustrated something that I am sure, I don't know that I've ever heard talked about before, which is, okay, what was life like? Like you said, you were a person before you were a patient. What was life like before? And when people see that incontinence on their intake, they're making an assumption. And you came in with this detective lens and was like, wait a second, I'm not seeing any clues that this was the case before. Let's do something to address this and change this, because I don't know if you have statistics on this, but I would imagine that because it's not being addressed, there's a high percentage of those clients that are going home with this new problem, and it's just now the new normal.
Right. Or they think that this is the new normal. Even with spinal cord patients, they're like, oh, I'm pooping all the time and I don't know when it's going to come, and I have to be sent back to my room out of therapy to get changed. This is my new life. And it's like, no. And if someone, if not all of us, don't say the real, educate the patient on how to manage it, educate family how to manage it, and just even explain you do not have to live in diapers. And there are definite ways to manage it, even with neurological injury. But what I even saw was a man that had heart surgery, had new incontinence. We did simple behavioral changes, lifestyle things, just kind of some training, time voids, and he got out of that. And then someone who had prostate surgery had a new problem that was limiting him from attending therapy. So not just spinal cord patients is who it's affecting.
That's incredible.
Yeah.
Oh, I love this. I'm so glad we're having this conversation. Weslina is joining us, and she said she's excited to listen to this. I don't drink sodas, so honestly, I'm not sure, but she guesses Coke. We have both in our area, but she notices the Coke more. Awesome. Keep those coming in. Gives us a nice break. And I don't know, it's just really funny to see the region specifics and people's answers to this question. So keep them coming in on replay as well. Awesome, Rebecca. So my next question is, what is one way that an OT can incorporate pelvic health into their evaluations, regardless of the client's diagnoses?
Okay, so I actually made a card It's laminated for my staff, my coworkers. And because they were like, I don't even know what to ask. I don't have time. You know, and at my facility, they have to do showers and everything in the eval. And they're like, I don't have time. I don't, you know. So I made this card of easy questions. One of them is, do you have any trouble getting to the bathroom? And then as a detective, we want to think, is it the mobility because you just had knee surgery, or is it because you have urge incontinence or frequency? And then one that you've mentioned a lot is like, how many times do you get up in the night to go to the bathroom? And one thing I want to make a point about is when we're doing our evaluation in acute care and inpatient, it's very important to say, prior to this injury or prior to this hospitalization, prior to this surgery, how many times did you have to get up and go to the bathroom when you were at home? Because I often found that people would either answer me how they used to be, like in, you know, in real life and not as a patient, or they would just say, I'm pooping all the time, you know, and it was post injury. So it's important for us to kind of ask both, you know, how they were before and has that changed since your hospitalization this time. And then you can move on to the rest of your eval. Another question you might find when you're gathering clothing or the patient's items, do they have panty liners in their packet, you know, in their little overnight bag? That's a clue. Or is it a man who has all his, you know, tidy whities and now he's in diapers? There's a clue right there.
That's awesome. That's fantastic. So what do you give that laminate card to your coworkers?
Yes. Yes. Yeah. And I'd be glad to share it. I gave an in-service. So I was like, here, you don't, you know, we're thinking on the fly, you know? So I was like, put this on your clipboard. Yeah. And on the back, it has strategies, behavioral interventions to address urinary leakage. So just kind of some of the normal things, and initiating a time void for someone who might be appropriate for that, or just to kind of give people who have never talked about it in school, out of school, things like that, just somewhere to start.
I mean, I have to say, like, just hearing that you had the initiative to make this card, to share this with your coworkers, like, can you give us a brief synopsis of how you came about this idea? Like, what was happening in your career, in your environment, where you were like, yeah, this is a need. We're not talking about this enough. I have such a passion. Like, I'm going to go out of my way. I'm going to create this card. I'm going to get this conversation going. I'm going to demystify it. Talk us through what happened there, Rebecca.
Okay, so what was happening was I was a generalist for a long time at this inpatient. I was 17 years there, but for a long time, I didn't do spinal cord. Then I was asked to take on spinal cord. So I started figuring out the toileting, bowel and bladder programming there because patients were leaving therapy with accidents. And I'm like, wait a second, I know I had a friend, I dated a man who was a paraplegic eventually. He had been a para for a while and he didn't wear diapers. He didn't have accidents, never had an accident the whole time I knew him. And I'm like, what's missing? Something's missing. So I started researching what was supposed to be happening. And so then I became the person who would be asked questions about their patient who was having accidents. And so it led to this process of people coming up to me in the hall. Hey, Becca, my patient has, what can I do? And I'm like, I'm late, you're late. I can't answer this right now. So I developed a system where I could do a consult. And so we would switch patients one day. I would do the consult on their patient, figure out what needed to happen, and create a bowel program or a bladder program for the patient, hand that to the staff, and then give it to them. And so the reason I came up with like this laminated thing was it turned out that then I became the one person doing all the consults. And I was like, at some point, you know, people were like, you're the expert, you know, and I'm like, no, I'm like, you all have this. Yeah. It's just a question. And, you know, and like I said, you know, people didn't even realize how easy it was to see or find a clue, and stuff that a lot of OTs did not think it was a scope of practice for us to be addressing bowel and bladder. And so I wanted to be like, wait a minute, this is a curricular problem. If we are graduating OTs thinking that, when the truth is we all had neuro, we all had anatomy, toileting is an ADL. And it's like, we didn't learn this in school. So I understand why therapists they questioned whether it was our scope or not, but there were so many other areas we didn't learn in school that are our job. So I decided to start doing in-services to boost people's confidence in these skills. And every single OT I know, and PTs, we want our patients to go home and be able to participate and be happy in those activities of life. And I didn't like the feeling when I didn't know the answer. So I wanted to share the info that I had found that I had kind of a hard time finding sometimes, so that people would know, just ask some questions and, build some confidence there.
Your coworkers are so lucky to have you.
Well, thank you. Thank you.
That's awesome. Weslina said she would love to see a picture of your card, if that's okay.
I will send it to her. I don't know how to do that like right now, but I will definitely send it.
If you maybe, you could just take a picture of it. I'm sure other people want to see it too, if you feel comfortable.
Yeah, sure. I think I have it on a PDF.
That would be cool too.
Yeah.
And Jamie Lynn is joining us. And about 3 minutes ago, you were talking about something that she said awesome about, but I'm sure she could just keep repeating that as you're talking here.
Thank you.
Love that. I love that. Okay. So I'm wondering what diagnoses should trigger a question about bowel and bladder during an eval. Are there some?
That's a great question. Definitely spinal cord injury, spine surgery. That's one that's often missed because someone had spine surgery, people think, oh, it was just bone. But oftentimes people wait to get surgery until they start having neurological issues like numbness in the saddle area, or incontinence, or the inability to empty your bladder, retention. So then you can start asking, did the surgery change whatever symptoms you were having?
Yeah.
And then stroke, frontal lobe. A lot of the patients that we were finding wet in the morning, soaking, OTs are always like, oh, I got to ADLs and my lady was so, drenched. And so we're like, ding, 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 time void, let's get this person on a time void program. There's not really the connection, I think, that we need to make more between frontal lobe diagnoses and continence, but judgment, communication disorders, where we can't let someone know that we might need to say something to them about, toilet, I need to go to the bathroom, but maybe they don't know how to tell you. Yeah. What other ones? Like I said, the cabbage, heart surgery, some people that have been on anesthesia, anyone constipated or having, I don't even like saying diarrhea, because we know so many people have the fecal leakage, and it's actually someone that's impacted with stool. And that's a confusing thing, I think, in general for people. And I'm dying to make some sort of visual thing that would show in real life that water can get past a blockage, to show that that's sometimes what's really happening. Because I will ask the doctor, can we get this person on stool softeners, more water, blah, blah, blah. And they're like, but they're having diarrhea. And I'm like, are they? So.
Oh yeah, that's a very confusing area. I did see a graphic one time, I think like Susan Clinton or someone did it, and she showed like stool like rocks with liquid coming down. And I think sometimes, like you said, like just that visual can start that conversation around that.
Yeah.
Any other diagnoses that you can think of?
You can think of MS, kidney cancer or bladder. I'm sure there's some that I'm just not thinking of.
That's good. That's cool. That's a nice long list.
That had surgery, I think.
Yeah. Weslina says she's seen a lot of people have trouble after getting a cath out with all sorts of surgeries, and a therapist doesn't even bat an eye about people having trouble.
Yep.
Yeah.
I mean, and I know for the rehab therapists out there watching, that's the time when the catheter arrives with the person, and it'll be days. And nursing hospitals have policies, and they're really pushing this anti-CAUTI, catheter induced UTI, acquired UTI program, and there's a financial reason for it too, but obviously for the patient's health and well-being, get those catheters out. But we just kind of see it as them. And I mean, how hard is it for an OT to teach someone how to do pants when they have a catheter? So we can be like, just as an OT, one thing you can do is just ask the doctor, hey, when's this Foley coming out? And your patient will love you.
I'm going to put that in the comments too. I love that. All right. So I love if you could share with us, Rebecca, and I Wesley just said, yes. Could you share with us what might treatment look like for an OT incorporating pelvic health at the inpatient setting?
So when we're doing self-care sessions, or when we're doing things like if you have a cooking activity that day or an IADL activity that day, anytime I saw a patient, I really liked to say, hey, we're passing a bathroom. Do you need to go? Same thing with water drinking. Hey, I'm going to get a drink of water. Can you want some too? I know that I was way dehydrated anytime I was at work, and I know everyone's like, yes. And think how dehydrated our patients are. And with that, if you ever hear a patient say, I'm limiting it because, I have this problem having to go to the bathroom all the time, that's an education opportunity to educate patients about a bladder irritant. When your urine is so concentrated, you can educate. Now that's a hard one for people to buy. I have not had much buy-in from people, but I know that they limit their intake because of the fear of having to go or have an accident. So then I would ask them, what is your biggest fear? Is it the risk of getting to the bathroom and falling? Is that how you fell at home and you ended up in the hospital with a hip fracture? A lot of falls happen in the bathroom. So even just during your rapport building, asking how their accident happened. Is it in the kitchen? They were rushing to get to the sink or water or fridge, or you were thirsty in the night, things like that. But always offer to take them to the bathroom and just put that detective lens on the whole time you're in there. Watch and see what happens when they try to go to flush. Do they lose their balance? For gentlemen or people with a penis who stood all their life to urinate, if they have horrible balance because of a head injury, I think we should allow them to stand, and you provide the balance they need so that they can empty their bladder in a way that is most normal for them. Now, I know that there are some people who try to encourage people to sit so that their pelvic floor will relax enough to empty. And, that's another thing to just watch for. And if it doesn't work the normal way that they have always done it, you've got something in your toolbox and say, hey, how about we try you sitting down, because you might be working your pelvic floor so hard and your buttocks and everything to balance that maybe you would empty better if you just were able to relax and sit down. Would you mind trying that? Things like that.
Love that. Lexi just said something that really hit home, which is she loves how naturally these opportunities for education arise.
Yes, it's perfect.
It's such a perfect match for OTs. I felt such a calling to this field over a decade ago, but I still light up one of the reasons I love doing these OT Empower Hours and connecting with the community is just hearing the passion, right? I was never in neuro, Rebecca. You are clearly this is your home. This is something that you really just light up about, and hearing and imagining my rotations, because I wasn't in a hospital very long in an inpatient setting. Lexi's exactly spot on. And it's just such a fit for us as a profession. It is such a fit regardless of your setting, because of that rapport building and those motivational interviewing questions that you're just weaving in there so naturally. I love this. Thank you. Thank you for sharing all this with us.
You're welcome.
So my last question, and I want to invite anyone joining us, throw them in the comments. We'd love for you to be a part of this conversation. My last question for you, Rebecca, is how can OT collaborate with nursing and medical staff to really help clients gain more agency over any of the tasks they want to do regarding bowel, bladder, or intimacy?
I'll touch on intimacy. I'm glad you mentioned that. We instituted a sign at the charge nurse office for persons who are wanting to engage after injury to see if they were able to have intimacy, whether it were positioning or whether or not they could get an erection or something like that after spinal cord. And so we just alerted to the staff who was working with them that evening that they might request this sign for privacy to be posted on the door. And we educated the patient, say, you and your partner just experiment. We don't know what your body's going to do. Things are new. Some things have been a little bit rewired. So we want you to feel comfortable exploring. You know, if you need some supplies, let us know. Talk to OT and PT about positioning if you want. So that was the intimacy intervention that we tried to collaborate with. And it showed staff that is an ADL, you know, and just be normal about it. Don't make a big deal about it. Be normal about it. And we are facilitating this person re-entering a part of their life that's super important. As far as collaborating in other ways with nursing, definitely, you know, be in the room. I think therapists wanting to take their patients to the clinic all the time takes you away from opportunities where nurses can learn and see what OT can do with a patient and how the patient benefits, but also how the nurse can then reinforce it in the room. And with that being said, it gives you in the room an opportunity to learn from the nurse, things that they've learned along the way that were techniques. The nurse might say to you, hey, Rebecca, last night he tried cathing, but, you know, there was a stricture or whatever. And do you know of any adaptation? So then we can start talking, and the patient sees you collaborating. These people have my back, you know, and I can talk to them about this part of my rehab that out in the clinic or the gym where everybody's lifting weights and stuff, I'm not bringing that up, you know. So opportunities to really be in the room. Ask nurses, you know, have y'all tried a different toilet setup? Did you know that he can lean now to reach under his bottom to perform, you know, hygiene or ditch stem? Did you know that? One thing also with pharmacy, there are laxatives and and stool softeners that take 12 hours to work. So find out what time that bowel program is and find out what time that med's being given, because a lot of times it was like this close to it instead of the night before. And it's like, well, he pooped last night. He had an accident. And I'm like, that's because he gave his med, you know. So ways like that to really just kind of like problem solve.
Oh my gosh. This is mind-blowing, really. Like it's so simple, but it's so profound. And it just takes someone with this holistic overview that we just as OTs excel in to go, wait a second, let's take a step back. Let's time the meds with rehab. Let's stay in the room where maybe some of these like all of this stuff, Rebecca, you're just demonstrating with such like day-to-day activities, how important OTs are in this space, that in the rehab setting, in the inpatient setting, people are not stepping into. And there's this gap. It's like, there's this expertise here, there's this expertise here, there's this huge overlap, this Venn diagram overlap, which is OT, that can bring it all together. And your approach is so empowering to everyone around you, your client, the staff. You're trying to bring them in. It's fantastic. It is so fantastic. Lexi said, this is wonderful. Such a simple way to signal the broad and beautiful scope of what we do. Weslina says, throw away the bedpans when you see them in the room and you know they are able to get up. Then of course, communicate with the nurse and staff about no more bedpan to get them up and going.
Yes. I think the collaboration piece and not being so siloed and thinking, no, PT does that, OT does this. You know, OT has a lot on our plate, so we're like wanting to finish what we're trying to do, but yes, don't be so siloed. Pull in, you know, and ask what the CNA has seen. What have you tried? Hey, do you mind giving me a hand? Can we try this scoop? Just really being more collaborative really will help the patient.
Oh, Rebecca, I'm so honored to have you here. How can people connect with you? How can people continue to learn with you? Let us know. Let us know all the things.
Okay, well, you can private message me anytime, comment on the OTs for pelvic health, and I'll see that there. Feel free to email me, and for now, that is what I'm doing. So
Okay, well, I hope you
stay
have more in the
tuned.
works. I hope you have more in the works because it's a lot to field those individual questions, but I'm so glad that you are. And I know your heart is so there and you want to help all of us. And we really appreciated that. But I hope bigger things are coming because we want to continue to learn from you. Thank you for being in our community. And thank you for continuing to spotlight all the ways that OTs are just awesome.
Thank you. And thank you for everything you're doing.
Oh, well, have a
Thanks
great
for
day,
having me.
everyone. We'll see you next time, same place.
Okay.
And have a beautiful day.
Okay. Thank you.